All right, let's jump right in. Today, we're going to be post-op detectives, cracking the case of what happens when a surgery goes perfectly, but the recovery goes dangerously wrong.
So here's a question for you. A surgeon does a fantastic job. Everything is technically perfect and the patient is closed up. Seems like a win, right? Well, not always. The real story, the true test, often starts after the patient leaves the operating room.
And that is exactly what we're digging into today. Those hidden dangers that can pop up days or even weeks later. It's all about turning a successful procedure into a lasting recovery, and that means you have to know how to spot the clues.
Okay, let's open up our first case file. This one's about a complication that can be hiding in plain sight, but you still got to know what you're looking for. We're calling it the case of the infected wound.
So, meet our patient. He's a 45-year-old guy. About a month ago, he had major surgery to fix a nasty femur fracture. He should be well on his way to healing, but he's back, and something is definitely off.
Okay, detective, let's examine the evidence. The wound just keeps weeping fluid. He's running a low fever now and then. There's redness around the incision, but the real smoking gun, that's seropurulent discharge. That's just a clinical way of saying it's a mix of clear fluid and pus. Yeah, that's a huge, flashing neon sign that his body is fighting an infection right there at the surgical site.
Now, let's look at the lab results, the forensic report, if you will. His white blood cell count is a little high, but it's technically still in the normal range. So that's a hint, but not definitive. But look at the C-reactive protein, the CRP. That's the body's big red alarm bell for inflammation. Normal is under 10. His is 25. That tells us something significant is going on, and it's almost certainly an infection.
And boom, there it is. The lab takes a sample from the wound, and the culture comes back positive for our prime suspect, Staphylococcus aureus. It's a really common bug, but it can be really dangerous in a situation like this. So we've got our culprit. The question is, what's the right move?
All right, let's put that case aside for a moment and open a new file. This one's a lot trickier. With the first case, the problem was pretty obvious at the wound site. This next mystery, it's much more insidious. We're hunting for a hidden clot. This time, our subject is a 62-year-old woman. She's 2 weeks out from a total knee replacement. She's also having problems, but her symptoms are going to send us down a completely different investigative path.
So, she comes in with a painful, swollen leg. Her calf is really tender. But, and this is a big but, her surgical wound looks perfect. It's clean, it's dry, no drainage, no signs of infection at all. This right here is a classic red herring. The crime scene isn't the incision. The problem is somewhere deeper.
And here is our first major break in the case, the D-dimer test. Think of D-dimer as the chemical dust left behind when a blood clot starts to break down. A normal level is less than 500. Hers? It's 1,800. That is sky high. After a big surgery like a knee replacement, patients aren't moving around as much, which puts them at a higher risk for clots. This number is basically a chemical trail leading us right to 1.
And here it is, the final damning piece of evidence. The Doppler ultrasound lets us see the blood flowing through the veins. A healthy vein is like a soft tube. You can easily press it flat. But hers is non-compressible. Why? Because there's a deep vein thrombosis, a DVT, a blood clot, blocking the popliteal vein right behind her knee. Case closed. Okay, so we've identified the bad guys in both cases, a nasty infection and a dangerous clot. Now for the most important part of the job, making the right call. What's the correct way to intervene? Let's check the playbook.
For our first case, the infected wound, the verdict is a 1-2 punch. You can't just give him antibiotics and hope for the best. First, you have to do a surgical debridement. That means a surgeon has to go back in, open the wound, and physically clean out all that infected tissue. Then, you follow up with antibiotics that are specifically chosen to kill that exact Staph aureus bug we found.
Now for our second case, the DVT, the verdict is all about one thing: speed. You have to start her on anticoagulants, blood thinners, right away. The big fear here isn't just the clot in her leg, it's that a piece could break off, travel to her lungs, and cause a life-threatening pulmonary embolism. We have to prevent that at all costs. You know, knowing the right answer is only half of it. A really good detective understands why all the other theories were wrong. So let's take a look at the red herrings, the wrong moves, and figure out why they would have been a disaster.
So for that infection, why not just take out the metal hardware they put in his leg? Well, because it wasn't loose or broken, it wasn't the problem. What about just giving him antibiotics? That won't work because bacteria form this slimy protective shield called a biofilm over the hardware. It's like a fortress, and antibiotics just bounce right off. You have to physically scrub it clean. And waiting just gives the infection time to spread deeper, maybe even into the bone. A terrible idea.
And for the DVT, some might say, oh, just use aspirin in compression stockings. No way. That's like trying to put out a house fire with a squirt gun. It's fine for prevention, but it's completely useless for treating a big active clot. Surgery to remove it? Way too aggressive for this situation. And just waiting and watching? That's the most dangerous move of all. You're literally gambling with the patient's life, hoping that a deadly piece doesn't break off.
So for that DVT, immediate anticoagulation is the only right answer. And today, the best tools for the job are called DOACs, or direct oral anticoagulants. These are the modern blood thinners. They're a real game changer because unlike old-school drugs like warfarin, they're easy to take and don't require constant monitoring. They're the standard of care for a reason.
All right, let's wrap this investigation up. We've looked at the clues, identified the culprits, and figured out the right course of action. Let's distill all of that into a simple playbook you can use for these post-op puzzles.
Here it is, your post-op detective's rulebook. Number 1, read the scene. Is the problem right there at the wound, or is it hidden somewhere else? 2, identify the culprit. Follow the clues from the labs and the imaging to figure out if you're dealing with an infection or a clot. 3, choose the right tool. A scalpel won't fix a clot, and a blood thinner won't fix an infection. And finally, number 4, and this is the most important, act with urgency. In both of these cases, waiting is the absolute worst thing you can do.
Just 2 cases, but they represent 2 of the most common and most distinct dangers that can completely derail a patient's recovery. You've got the obvious, localized infection versus the silent, hidden clot, 2 totally different villains requiring 2 totally different strategies.
And really, that's what it all comes down to, isn't it? The body almost always leaves a trail of clues. The swelling, the fever, the weird lab results, they're all part of the story. The true skill is knowing how to listen, how to read that story, and piece it all together.
Which leaves us with one last question. We cracked these 2 cases today, but you know they're not the only things that can go wrong. It makes you wonder what other hidden dangers are out there, just waiting in the shadows after that final stitch is placed.